So I'd like to welcome everyone to our annual meeting, and the first order of business is the election of directors. The nominating committee has put forth a slate. The slate includes Greg Troy from Command Corporation, Eric Murray from Timken Steel Corporation, Mark Truschel from Mantaline Corporation, Joe Chaddock from the Stark County Educational Service Center, Mark Spears from Campbell Oil Corporation, and Susan Marsico from Vertiv Company. Could I have a motion to accept the slate?
I move to accept the slate.
Thank you. And a second?
I second.
Thank you. All those in favor signify by saying aye. Aye. Any opposed? And just for the record, all the proxies of those who aren't in attendance were proxied to me, and I will vote yes as well. So I'd like to now introduce our speaker. And Mike Stahl and I had the opportunity to hear him speak in July in a very hot Las Vegas. It was about 115 degrees, but we were indoors, so it was great. And I think you'll find him to be an exceptional speaker. He's very well-rounded. I think if you're in the employer space, the hospital space, the managed care space, you're all going to get some great takeaways from this. He is Bradford Koles, and he is the Executive Director and National Spokesperson for the Advisory Board Company. He's a thought leader in health system economics and strategy. I learned last night over dinner that he is a native Ohioan from Toledo. He has an undergraduate degree in economics from Kenyon College and a master's degree from Johns Hopkins University, also in economics. So, Ford, welcome.
So, I apologize. Is that too loud? I have a bit of a cold, as you can probably hear. So, if I make any really disgusting noises, I'm sorry. So we were casting about trying to find a theme for our State of the Union this year, and we landed on disruption, as you can see, which I feel a little bit embarrassed about. Maybe I should. What if I reverse it? What if I just use this? Can you hear me? No, can't hear me. Emily, that should be better. Much better. So I'm a little bit embarrassed that we called it disruption because all conferences are about disruption now. You know, it's like, oh, what a surprise, you chose disruption. A headhunter told me I had entrepreneurial on my resume, and a headhunter was like, take that off. Nobody puts entrepreneurial on their resume anymore. It's been ruined. And that's how disruption feels to me now. But the truth is, it's a cliche for a reason, right? Because we are in healthcare, I think, in an era of disruption. I've been working in healthcare my entire adult life as an economist, and it's a huge industry in the world's biggest economy, right? So there's never been a time in my career, you tell me, there's never been a time when there hasn't been a disruption to talk about in healthcare. Whether it's the Balanced Budget Act of '97, the Clinton Plan, Columbia HCA and their horizontal moves in the 90s, there's always something that, there's always a disruption in, specialty pharma, there's always a disruption of some kind in this industry. But that doesn't mean I would call every era an era of disruption. You have to hit a certain level of, I think, activity and intensity to be called an era of disruption. But there is absolutely no question in my mind that we are in one now. If you look at all of these moves going on, including at the sponsor organizations today, right? Lots of big vertical moves going on in the industry. So I want to talk through those things. I designed this largely in three parts. First, who are these disruptors? What do they want? Like, why can't they just leave us alone, right? Why can't we just do our thing, like our magic? What do they want? It's fun to talk about them as protagonists. I don't know about you, it's like a bad airport business book, you know what I mean? The disruptor who released all the value to the consumer and the end user. So some of you know me personally and you know this. When I was at Kenyon here in Ohio, my girlfriend was at University of Vermont in Burlington, Vermont. And I was stone broke. I mean, I didn't have 2 dimes to rub together when I was at Kenyon. I was on a shoestring budget. But I used to fly once a month to see that girl, Columbus, Newark, New Jersey, Burlington, Vermont, and back, once a month on what airline? What airline could I afford? People's Express. Remember that horror show? Remember that airline? I mean, it was just the worst possible. You basically had to row the plane like it was, they had like a cash cart on the plane. You remember that? There was no drinks cart. There was a money cart. They would push it up and collect money. You were giving them like wooden nickels and IOUs, right? But it was like $103 for me to get from Columbus to Burlington and see my girlfriend. They were a hero to me. I could never have flown Eastern. I could never have flown United or Delta. It was way out of my price range, right? So we look at these disruptors as heroes, as protagonists. But let's also remember, this is particularly true for the healthcare people in this room, that they're disrupting someone, and that is largely providers and pharma. So for the hospitals in the room, if you want to feel a little bit better, be like, those pharma guys make a lot of money. What about those pharma guys, right? And it's not personal, it's just that's where all the money is. Hospital, physician, and drugs are the vast majority of the money that the people in this room spend on healthcare. Payers are just in third now. Providers and drugs are the big ones, right? So again, it's not personal, it's not vindictive, it's math, which is the disruptors go where the money is. So in the second part, I want to go deep on what does this mean, right? What are they changing about healthcare, these disruptors? What would they do for employers? What would they give you that you don't have now? What options? And then last but not least, I'll finish up with a few words about who wins in this, right? How do we win? How do we make sure that the good healthcare systems in Northeast Ohio are at the table, right? And doing something good. All right. I don't know if this has happened to you in your house, but the last year have brought out this weird inner closet monarchist in my wife, because she makes me watch this crap every weekend. Megan's on. I don't care. I don't care that Megan's on. Like I didn't even watch Suits. Like, I wasn't interested in Megan when she was just a successful actress. I'm not more interested in her now that she's a princess, right? But my wife is obsessed, and she's gotten my 14-year-old daughter now. She's infected her with the same disease. Like, Dad, the princess is on. It's not our princess. Like, I try to remind the two of them, like, we fought a revolution to be free of these people. Like, I don't know, did you miss that in social studies? Like, it went on for a long time. Lives were lost. Like, so, and now that Megan's pregnant, like, and she's like, they're holding up baby Louie outside of London. I'm like, what is this, Lion King? Like, I don't care. But I want you to know, if you're like me, and you think the British royal family is an unconscionable waste of public resources, I want you to know that every baby brought into the world in Northeast Ohio costs more than baby Louie did to bring into the world in a fancy London hospital. Every single child brought into the world in Cleveland, Akron, and Canton, and so forth, is more expensive. Don't think that our lovely children are not spoiled, right? They cost more. And don't even get me started on the American royalty. I give you Beyonce and Jay-Z on the right-hand side, who renovated an entire suite of Lenox Hill Hospital so they could not only have their babies, but have their whole entourage there at the same time. The New York Post reported that they spent $1.3 million renovating that part of the hospital. I talked to the CEO of Lenox Hill, actually chastised me personally. I was talking about this figure. He yelled at me, he's like, first of all, it's the New York Post, which means de facto it was wrong, And then he's like, he got this weird expression on his face. He's like, it wasn't any more than 600,000. I was like, I feel a lot better. Like, great. Do you think most people in Northeast Ohio understand this? Do you think most people in Northeast Ohio understand why healthcare costs twice as much in the United States as it does in the next 9 richest countries on earth? Do you think they have any idea? I mean, it's your job, right, to understand this, but I think you're alone, right? Most people don't understand this. I mean, most sophisticated people don't understand this. Honest moment, I wonder sometimes if we understand it, myself included, right? This is all I do, and I sometimes scratch my head. You know, for example, this is a study that came out recently. This is from the OECD and the Commonwealth Fund. But it was a big study, but it actually is echoed by a number of smaller studies that have come out recently, which are sort of poking holes in the traditional reasons that you and I have given for why American healthcare is so expensive. What have we always said? Why is healthcare so expensive in the United States? Why? Why? Utilization, right? What have we always said? Physicians are, trained to pull out all the stops, to do everything, leave no stone unturned. Every test, every procedure, every diagnostic, right? They're afraid of lawyers, they're afraid of being sued. So of course they order everything, right? Utilization. They feed their own surgery centers. Hospitals are fixed cost entities that are feeding their own businesses, right? This is what we've always said. Well, this is a big study that compared, it's a longitudinal study. If you track a 33-year-old American and a 53-year-old American and a 73-year-old American through the healthcare system, and then you compare that to the next 9 richest countries. You know the cast of characters, Germany, Australia, Japan, England, Switzerland, right? Sweden. If you compare what happens to those Americans, it's identical to what happens to anybody in those other countries. They see the same doctors. They spend the same amount of time with the nurses. They take the exact same drugs, literally. There's only one thing that still pops, by the way, in the US system. You know what that is? There's one thing that sticks out, and it's scans. We still do way more CT and MRI work than anybody in the other 9 next richest countries. But it sticks out because it's the only thing that sticks out. Everything else is like identical. And you're going to yell at me, and it's not my study, but this study is also claiming that it isn't social spending. Right? I mean, how many times have we scratched our heads around this? If only Canton were Stockholm, cradle to grave nanny state assistance from the government, right? Every time you fall down, somebody from the government picks you up, dusts you off, get back in the game, kid, right? Better child care, better maternal and paternal leave, better, cheaper, public health care, all of these wonderful things. As it turns out, Americans, as you know, give more money to charity than any other people on earth, by far. So if you measure public and private social spending together, now the problem with that measurement is I have no idea how the money's spent privately. It's Bill Gates who chooses malaria one year and then it's another thing the next year, right? But if you measure the public and private social spending, this is Stockholm. We spend just as much on these things as the #1 nanny state in Scandinavia. So let me ask you then, if it isn't social spending and it isn't utilization, what is it? What is it? Prices. It's prices, unit price. We're far better paid in this country in healthcare than anyone else is, by far, right? Nurses make much more money in the United States than they do in France. Doctors are far better paid in this country than they are in Japan. Right? Administrators, leaders are far better paid in the United States than they are in Sweden. People who speak to hospitals for a living, this guy, I don't know who this guy is in Germany, but I'm kicking his ass. We're all better paid than the healthcare people in other countries, which to me speaks of a disruption, doesn't it? Doesn't that speak to you of disruption? Because if unit price is the problem, if unit price is the issue, that has to be a disruption. Who in human history ever fixed their own unit price? You tell me. Who ever walked down the street of Akron I make way too much money. This is ridiculous. I've got to release this value to the consumer. This is nonsense, right? Nobody's ever done that, ever. in human history. It wasn't Eastern and United who got me to Burlington, Vermont. It was People's Express. They disrupted the other airlines, right? So this speaks of a disruption. And here they come, right? And as I said before, remember they're targeting drugs and hospitals and doctors. Those are the targets. Again, it's not personal. That's where the money is. Led by these hardcore service companies, famous for their customer service, famous for their transactions, famous for their savvy and their use of data, led by Comcast. That was a joke. If Comcast is our service disruptor, we have a serious problem. No offense if Comcast is here, you do great work, but like I had Comcast for 20 years in DC, and I mean, they weren't famed for their service quality. I came home once and my wife was sobbing on the front steps and I was like, I knew it was Comcast. If it had been cancer, she would have called me. You know what I mean? For 3 days, the cable company had said, oh, we're gonna come, don't worry, between 8 and 8. Just give up your entire life and wait for us. For 3 days, she'd waited for them and they hadn't shown up. She was sobbing, I kid you not, sobbing on the front steps when I drove up. I was like, it's Comcast, it has to be Comcast. So this is Comcast, who was actually doing some interesting things with patient care technology and communications. I'll talk about them a little bit later. But of course, it's Apple, Google, Uber, Lyft. It's all the companies you read about, not in the business pages, in the front pages of your papers, right? Companies that are doing a lot of disrupting all around the economy. Companies whose stocks have not been doing well the last few weeks, ouch. And of course, Amazon, big A, right? The serial disruptor. Did you see what happened to the drugstores when Amazon bought PillPack? Did you see that? So Amazon buys kind of a second-tier pill distribution company. Did you see that? How much value did the drugstores lose in one day on Wall Street? Did anybody track that? $22 billion. In a day. In one day, Wall Street was like, you're worth $22 billion less because Amazon buys a pill distribution company. I mean, that is a disruption. Right? They've made some of the money back, right, in the next week, but that's an amazing thing. And they're focused on us. Now, let's also acknowledge, we've heard about some of these stories before, haven't we? Remember when Microsoft was going to disrupt the medical records business with the Microsoft Health Vault? They just shut that thing down this year after losing untold sums of money trying to make it work. Remember when Google was going to eat Epic's lunch? Because they were going to come up with this like medical record in the cloud that was somehow going to be HIPAA compliant, right? They shut that thing down 6 years ago. Remember when Walmart was going to remake primary care? Remember that? Walmart was opening clinics all over the United States. And they were going to, how's Akron General going to compete with Walmart for doctors and nurses? How are they going to pay more money than Walmart? They're all gone. They shut them all down. Walmart still experimenting with this model in 3 southern states. They've shut down so many of these clinics, right? So you're right to scratch your head and say, is this real? Are we going to be laughing about Amazon in 3 years? It's a fair question. I think it is real. I don't ask you to take my word for it, I'll show you. But I think it's real because of the level of activity and also because the economics match the news stories, which is always intimidating, right? This is a unit price problem in our country. And if unit price is the problem, I promise you, there's only one thing that ever changes unit price, and that is outside disruption of an industry. So every time I think I'm overestimating Amazon, I remember my friends who worked at Borders. I liked Borders, didn't you? It was like the cool Barnes & Noble, you know what I mean? It was like the edgy, it was like the W to the Marriott, you know what I mean? Like a little edgier, you know? Gone, right? Gone. I remember my friends who worked at Circuit City. Oh, I love Circuit City. I got my first big screen television at Circuit City, right? Long gone, right? And what, 2 months ago, finally, the last gasp, the death rattle, Toys R Us. You know, like, they took the giraffe out. They ripped the giraffe out of the headquarters and stuck it in a children's hospital. By the way, if you're business people, and you know, those companies, all of them had other issues. They had debt problems, really bad leadership choices. But the truth is, if you ask somebody who worked at Borders or Toys R Us, what do they tell you? Amazon killed me. Toys R Us said that every analyst call. Amazon's destroying us. Right? That's what they would say. So it wasn't just debt and leadership problems. Amazon destroyed those businesses in some sense. Right? And now there's no question they're coming after drugstores, right? And a number of other things. So we put on one slide for you all the things we've seen Amazon do recently in the marketplace. By the way, I could have put 100 things on here. That's a scary thing, right? These are just the big things I've seen in healthcare. What is Amazon up to, right? What do you see here? What are they up to? What does this slide say to you? When I first looked at it, honest moment, I was dismissive. I was like, they're all over the place. They can't make up their minds. Is that what you see? No, right? They're testing us. They're poking and prodding. They're trying to figure out the best way in, right? And the amazing thing is, right, for these guys, for Amazon, unlike hospitals in Northeast Ohio, you know, they lost $130 million. Oh, bummer. Damn it. Like, let's start over, right? I mean, imagine Akron General lost $130 million. You know, they can afford to do all kinds of weird things and experiment with the industry. They're nimble, and they can afford it, right? So these are the big five. These are the things we're tracking right now in terms of disruptions from Amazon. And by the way, I could have used any company, because there are other competitors in every single one of these five spaces. But Amazon's a fun vehicle, so I just use them. Employer aggregator, right? So this is the Amazon, JP Morgan, Berkshire Hathaway coalition. They're going to look at buying healthcare, right, more cheaply and intelligently than they do now, right? They talked about sort of telemedicine and wellness applications. Did you see when Atul Gawande did his press conference as the new CEO of that thing? I thought he was going to talk about kind of neat telemedicine applications, kind of techie. He was like, there are too many middlemen, we got to kill the middleman. I was like, whoa, Atul, where's the anger, man? I mean, it was a disruption conversation. It wasn't like a neato telemedicine conversation. It was, there are too many fingers in the pie in healthcare. We got to get some of those fingers out, right? It was a disruptor talking. Next generation retail pharmacy. This is PillPack. There's no question in anybody's mind in this room, I would bet, or anywhere in healthcare, that Amazon is coming after the drugstores. Listen to their analyst calls, right? They're coming. They feel they could do that better. Global healthcare logistics specialist. Amazon's been making the news a lot because they're helping rural hospitals improve their supply chain, which is cool. I like that, right? I read this funny story of the CEO of Intermountain in Utah, who was one of his surgeons burst into his office in a rage because he said, I had ankle surgery and I got the boot in our health plan, our generous health plan, and it was $230 in our health plan. And just on a lark, he said, I went on Amazon and I got the same damn thing for $30. He was literally like, you owe me $200. I want it right now. You robbed me to cross-subsidize all your other crap. I got that thing on Amazon for $30, right? What will Amazon do to the supply chain? And then the mother lode is this fourth one. What is Amazon best at? Every person in this room uses them. What are they best at? Every single one of you use Amazon. Why? What are they good at? Why do you use them? Transactions. They make transactions so easy and nice. Think about it, right? Click. Oh, it's coming. So nice, right? I want you to, no offense to the people in this room, since this is one of your purviews, but I want you to compare that transaction to the open enrollment for benefits at your company. I have to take Xanax every time that comes around. Because it's such a freaking nightmare at our, oh God, my doctor, oh, what's the copay? Oh, it's a $3,000 deductible now. Like, it's not a fun transaction. And imagine if they could one-click that. Imagine how much market share they would take or switch if they could one-click that. What else is Amazon really good at? What are they really good at? Data, right? Collecting unbelievable amounts of information on all of us to figure out who the hell we are and what we want. That's what they're good at. Remember when Target figured out who was pregnant by what they were buying at Target? Do you remember that? Does anybody remember that story? They started sending out congratulations emails with coupons. Did you see that? And then what happened? Does anybody know? They sent one to a 16-year-old whose father got it. It was like, pregnant? And then somebody at Target was like, stop, you know. If Target can figure out who's pregnant, you're telling me Amazon doesn't know what's up with every single person in this room? Of course they do, right? They know everything about you already. They know who's depressed here, they do. They know who has joint pain. They know who's pre-diabetic. They know who's diabetic, right? Of course they do. Think of all the things you search for, all the things you buy, all the things you look for. They're recording all of it, right? They just haven't figured out how to monetize it yet. Now, Amazon wants this data, Google wants this data, every insurance company wants this data. Every hospital system wants this data. Everybody wants this data because this is the future of healthcare. Right? How much better could diagnoses be in Northeast Ohio if we had access to all that information, right? How much earlier could we intervene in people's lives? How many people are hobbling around Akron right now who need joint surgery and they're just sucking it up? It's probably 20 or 25% of the market. Right? There are so many things we can do better than we do now. And last but not least, right, they're going to be a primary care operator. Amazon has been opening primary care clinics in their own facilities on the West Coast. Nobody thinks they're doing it to be nice. They're experimenting. If they stick primary care physicians in their offices, how much more cheaply can they operate a healthcare enterprise, right? And what's their physical footprint? What do they own? Whole Foods, which means they have a physical footprint in the nicest part of every nice city in the United States, right? Now, as you can plainly see, I'm not a millennial. I don't want to get my flu shot where I buy kale. I think that's odd and gross, right? But I got to tell you, the 20-somethings that work for my company, oh my God, it's like a dream come true. You're kidding me. I can get my wellness and my crumpets in the same place? Like, I mean, it's just a completely different group of people, you know what I mean? They're not us. They don't have the same loyalties that I do, right? And the thing is, everybody's trying to get their loyalty right now. And people like Amazon are the ones who have it. Right? We're all trying to figure this out. So they're going to be a primary care operator, we think, as well. All right, here are the big three for me. This is what I want you to think about as employers and also as healthcare people. The rise of the hospital-less IDN, Integrated Delivery Network. There are a whole bunch of vertical moves I'm going to show you in a minute, and none of them involve the hospitals and health systems. So for the hospitals and health systems in this room, is that like, oh, a sigh of relief, oh, whew. Oh good, they're not bothering me. Is that how you feel? No, right? So what do these people say about the hospital? Oh, I'll get to you, don't worry. I'll get to you later, right? I want to control, Mark Bertolini, CEO of Aetna, said, we want to change the front door of the delivery system. We'll get to acute care later, don't worry, right? But that's not what they're targeting on now. For the people in this room, for many of you, the resurgence of the activist employer. There's a big sea change, a big mood change going on. And you tell me if I got it wrong in Northeast Ohio. But there's been a big mood change among employers that we've talked to because they're sensing the beginning of the end of the high deductible run. And if they don't have more deductibles, then you know what? They're going to have to start looking at the price again. And that's not what they've been worried about. And then last but not least, what's going on with the government? What's going on in Columbus? What's going on in DC? By the way, I think it's amazing, just a note, this is the first time in 10 years I've done a State of the Union where I didn't start with Washington, DC. I just think that's important. We are not political. We are nonpartisan at the advisory board. We do not take sides. I do not care. It is not my problem. But I got to tell you, I mean, what a difference between Obama and Trump, right? We hired a bunch of the Obama people. You know, people tend to burn out in the White House because it's a hard job. They don't pay very well. So we hired a bunch of Obama people. We've hired Trump people too. And the Obama people had all read this book called Nudge. And when we hired like 5 of them, I was like, all right, something's going on here. They've all read the same damn book. And Nudge is this, it's one of those airport business books, but it's basically about how the federal government, you know, can be used to sort of change healthcare. If we change Medicare and Medicaid, it'll nudge the private economy along to do the same things, is the writ large, that's the idea, right? And the Obama people bet on hospitals and health systems. Why? Not because they love you, but because frankly, they needed you. They needed you to implement the Affordable Care Act. Right? Who's going to implement meaningful use? Onesie and twosie physician groups in Canton? No, nobody has that kind of money. You need big organizations to implement the Affordable Care Act, right? So the Affordable Care Act is a bet on major system healthcare. The Trump people are not reading Nudge. It's not what they do. They do not care. They're truly neutral. They're not against you. It's just they're not in favor of you either. They will take whatever model they think can give answers. And they would much more like to sort of import private sector ideas into the government than vice versa. So it's a real sea change in the attitude. So I'll talk a little bit about that. So here are the big ones, right? Just take a look at this for a second. A lot of these have been approved now. Right? This isn't myth. And this is every street corner of Akron and Canton. Every street corner. It might not be hospitals and health systems, although it's certainly doctors, right? But this is amazing. This is a huge change. If all of these go through, you and I are looking at a completely different healthcare market a year from now. This is every street in our cities that is changing. You'll see two things are going on here. I put them, these are the four that we study the most: Cigna, Express Scripts, CVS, Aetna, Walmart, and possibly Humana, and Optum buying a bunch of physicians everywhere, right? The two things that are going on here at the bottom of the slide, first of all, the pharmacy benefit management company, something you guys talk a lot about and having a conference about, is being reintegrated into the insurance company, clearly, right? Which is a little strange because PBM started in insurance companies. It was a division or a department of insurance companies, right? And then some really, really smart person many years ago was like, I think this thing would do better if it were by itself, if it were a focused factory, right? Whoever that person, whoever that man or woman is, they're on a yacht because it really worked, right? PBMs exploded in growth. But now they're being brought back in. They're being brought back into insurance companies, which is interesting, I think. And then the other one is, this is Mark Bertolini's quote, CEO of Aetna, rebuilding the front door of the delivery system, right? CVS, Aetna, Walmart, Humana, Optum, DaVita. Let's go through them. First of all, on the left-hand side, if all of these go through, 75% plus of the pharmacy benefit management business will be back under the roof of an insurance company. Why? If you ran an insurance company, why would you buy a PBM? There better be a hit over the head reason, because it's $67 billion. I want you all to be like, well, that's a no-brainer. Why would you do it? Why would you buy a PBM if you ran an insurance company? What? Control pricing, right? What's the worst part of the medical loss ratio right now? Drugs, right? That's the part of the medical loss ratio that looks the worst right now. So you're going to try to rein in the drug spending, better formularies, better compliance. That's the whole point, I would assume, right? You think you can rein it in. This isn't insider trading, but United's done well with OptumRx. And if you talk to Cigna and Aetna and the Blues, they'll say, you know what, I don't know what United's doing, but they're managing a better medical loss ratio on drugs than we are. So, and we think it's that PBM of theirs. That's what they say. It's not insider trading, I read it in the newspaper. That's what they say, right? So it's, again, bring it back in. Now, does this radically change the price of drugs in America? Is this going to take a drug that, a specialty pharma drug that you spend $130,000 on, is it going to make it cost $5,000? Anyone? No. It's around the margins. I'm not saying it's irrelevant. It's just not People's Express flying me to Vermont. It's not a radical disruption of the cost of drugs, right? Is this? So this is Intermountain and Friends starting a generic pharmaceutical manufacturing plant in Utah. That's interesting. Why? You guys all spend this money on drugs. Are generics where the inflation is? Are generics where all you're seeing all the inflation you're spending on drugs? Yes or no? No. Specialty pharma and brand, right? Now there is some inflation in generics, isn't there? When is there inflation in generics? When there's a supply problem, right? Oh, there's no saline, sorry, it's gonna cost 6 times as much, right? Oh gosh, there was a hurricane in Puerto Rico. We don't have any aspirin, right? Then they jack up the price of the generics, right? Well, what Civica is saying is no more. Every time you tell me there's a supply disruption and you're gonna jack up the price, I'm gonna make it. I'm going to manufacture it and sell it at cost. No more. It's not the heart and soul of the inflation problem in pharma. But I think it's more of a disruption than the last thing I showed you. We'll see, right? Somebody else is in the game now. A provider system is getting into the pharma game in some way, shape, or form, which is de facto more disruptive, I think, than the last thing. All right, let's go to the front door of the delivery system, because this is a little bit closer to our hearts here. CVS, Aetna, Walmart, Humana, Optum Care. Look at the physical footprint of these organizations at the top. I mean, it's just startling, right? 10,000 retail stores for CVS. 70% of the American population lives within a 5-mile drive of a Walmart. 70%. Optum Care buying physicians all over the country. They employ 30,000 plus physicians now, more than any other entity in the United States. So if you're CVS, why do you buy Aetna? Why? Why would you do it? Why would you buy Aetna? Why would a drugstore buy an insurance company? There's got to be a good reason. Again, it's tens of billions of dollars. Why? Why? What? Go ahead, say it. Control their own supply, right? I have to imagine. CVS is also going to build a whole bunch of clinics. That's what they've been talking about. So there's some disruptive stuff here. CVS wants to be able to run basic clinics so they can treat these enrollees more cost effectively than they might be treated in the health system. But a lot of this is upstream. They're trying to go upstream to make sure they have their clients. If I'm fearing Amazon, if I fear Amazon's going to disrupt me, well, here's a good way to make sure I continue to get business, which is, I'm guessing, they've not said anything about this, but I'm guessing if you're an Aetna enrollee, you're going to get a memo which says, oh, we got your drugs. It's called CVS, right? You want it delivered by a robot? I'll bring a robot, but you don't get Amazon, you get CVS. If you were Walmart, why would you buy Humana? Why would Walmart, and this is still rumored, but why would Walmart buy an insurance company? You been to a Walmart recently? Who else is in there? Who's around you in a Walmart? People with Medicare Advantage, right? Every time I'm in Walmart, I look around, I'm like, I'm the only person in here who's not on Medicare Advantage, right? It's all Medicare Advantage. It's not just people that are older than I am, it's people who are older than I am and on Medicare Advantage, right? There's a huge crossover here. What could they sell? What kind of foot traffic could they get, right? What kind of services could they provide to these people? Could they have the MRI by the tires? I don't know, right? And then Optum Care buying physicians all over the country. Let's go deeper on that one because it's the most developed, right? So Optum Care has bought physicians in 30 marketplaces, excuse me, and they're purporting to go to 75. Why is that? It's a big country, isn't it? Why so modest, Optum Care? Why only 75? Why isn't it 475? Why isn't it 2,075? What do they buy? What does Optum Care buy when they go after doctors? Do they buy onesies and twosies in Canton? Who do they buy? They buy massive physician groups. New West, Reliant, WellMed, DaVita. These are physician groups you've heard of. You know why? Because they're already famous for doing care management and population health. What Optum Care is doing is buying giant organizations that are fiercely independent of hospitals and health systems that are already good at population health and care management. So they're going to scale this model to something much bigger, right? But that's not 2,075 markets, that's 75 markets, because there aren't that many physician groups like that. Right? Keep in mind, this is a very different vision of the future. They are not going to buy hospitals. They will never buy hospitals. This is a vision of the future of healthcare in Northeast Ohio, which is largely controlled by doctors. And then the doctors get what they want because they have the power of the purse and they're dictating terms to everybody else. That's what this model looks like. I was in central Massachusetts recently, and the hospitals there, 50% of their medical staff is Reliant, that medical group. So there's no war. They said, the war's over, we lost. That's 51% of my medical staff. There's nothing I can do about that. All I can do right now is be appealing to those guys now. That's my game. Be more appealing to those physicians than that hospital is. So this is a very different vision of the future than what is typical in Northeast Ohio. All right. You tell me if you're feeling this pain, but issue 2 is spending's back up. Healthcare spending. Your spending for the employers here. What we were hovering down near just above general inflation on the left-hand side, and then it started to pop again. Then it started to climb again, right? And if you look at 2017 and 2018, it looks like this. So it's back. You know, for a while it looked normal. It looked almost like everything else in America, right? Like gas and air and salaries and raw materials and all the other crap we do, right? And now all of a sudden it's redlining again. Because I'm guessing you see this every single day. This is your job, right? It's back up again. Why? What happened? Well, what happened generally is everybody moved to high deductibles. And that continues, by the way. This isn't over. We're all still moving to high deductibles. I have a $3,000 deductible now, right? Which a lot of physicians are like, that's not high, that's normal. Don't complain about your deductible, that's a normal deductible, right? 3,000 bucks. Well, so everybody's been moving to high deductibles, right? What happens when you move to a high deductible if you're an employer? Two things happen, right? First of all, I offload 4,000 bucks onto my workforce. That's nice, because now it's your problem too, right? You got to be careful. And what happens to utilization? What happens to utilization in a high deductible health plan? It goes down. We have studied multiple workforces at the advisory board to try to understand the impact of high deductibles. Utilization goes down every single time. Low income, middle income, high income, every single time utilization goes down. Now, it doesn't go down 50%. It doesn't go down 2%. In our studies, it goes down every time between 13 and 17%. Every single time. 13 and 17%. Now, I know what you're wondering, because you're good people. Are we lining up some sort of healthcare catastrophe 10 years from now? Because everybody's not taking their drugs and they're going to come into your hospital in a diabetic coma, right? The truth is, we don't know. Honest moment, I don't know. I don't know if they're getting rid of inappropriate utilization or they're not doing something they should be doing. The only study I've seen that made this point at all, it was published in the New York Times about 2 months ago, and it was a study of mammogram rates in targeted populations that had high deductibles, and the mammograms had gone down, and that's not good, because these are women that should be doing mammograms. And it hadn't dropped 50%, it had dropped a little bit, but again, that was concerning, because they were in the target population. It's also an issue of, you know, varying protocols and disagreements as to who should be having a mammogram, as you know. But again, some of the issue is clearly high deductibles. Here's the problem, right? So this is how employers like you have been keeping the cost down. You can see over here, is I offload a lot of the expense and then utilization goes down because of the high deductible. So that keeps the line at a good place, even if the prices look ridiculous, because I hold the line down with the deductible. Well, what's happened is a lot of employers now are saying, I don't have $2,000 more of a deductible in me. It's already disrupting my workforce. The labor market, employment is at a historic low. The labor market is white hot. If I jack the deductible up anymore, I'm going to lose my best people. They'll go somewhere else. So, Minnesota has the most high deductible health plans in the United States right now. Per capita, there are more people in a high deductible plan in Minnesota than any other state, far beyond Ohio. And when we were in Minnesota a few months ago talking to these employers, they were like, we're done. Whatever we're going to get out of this, we got out of this. So we got to look at other stuff. Now that's a big problem, right? Because the minute you can't jack up the deductible anymore, you have to start to look at the prices. And the prices are bad. The prices are way up, right? Because nobody's been worrying about it. So what you have, and again, you tell me because you're employers, is this attitude switch. Everybody in the Obama era was going to abdication. That's not an insult, it's an economic term, which means I don't want this, I want you to have it. So, I want to set up a private exchange for my workforce. I'll give you 5 health plans to choose from, and I'll give you a health savings account. You go shopping. It's on you, not me, you. Or I'll set up a direct ACO, or I'll do something. If I have a low-income workforce, I'll push them into the exchange in Ohio, right? But all of these things are abdication. They're all pushing things away from you as an employer, right? Well, if price is the issue, you have to move over here to activation, because I got to get my hands in again. I got to get out there and negotiate with people and bring the price down. And that's what's happening. That's what we're watching. Let me give you one marker of it. Direct ACO contracts are a kind of activism because these are health systems and major employers sitting down and working out terms of how they want healthcare to happen in a marketplace. ACO, Accountable Care Organization contracts. General Motors just signed one with Henry Ford in Michigan, right? We saw a whole bunch of these in 2014. The most famous were Boeing and Intel. Both signed these huge arrangements in their factory towns with the local health systems. Now, there are insurance company components to this, but it's basically the health system and the employer sitting down to work it out, right? All of a sudden, we heard nothing about it for 4 or 5 years. They never came up again because all the employers that we were talking to were going to the deductibles. These are complicated and difficult. They're like, what the hell with it? I'll just do the deductible, right? Look at the right-hand side. All of a sudden, they're back. We're reading about them all over the place again. Disney, Dart, Whole Foods, right? General Motors. All of a sudden, they're popping up again, which is interesting. Here's the problem. So for the health systems in the room, right? And for the employers in the room, do you think it's a happy relationship right now? No. They don't say it publicly, but if you talk to Boeing or Intel behind closed doors, they talk about how difficult it is. And by the way, Providence will talk about how difficult Boeing is. It's not been an easy relationship. Because what Boeing says is, you guys are volume junkies. You just want to utilize all the time. So we get into this relationship with you, you're supposed to save money for me, but you end up telling me everybody's sicker than you thought they were. And then we jack up the utilization, right? So you are either going to be the solution for me or you're a problem. So that's my worry here, is that I want the health systems in Northeast Ohio to be the solution for the employers in this room, right? Not volume junkies, not seen as part of the problem, but seen as part of the solution. The other problem is this one, right? Which is inconsistent outcomes. As employers, what you want to buy is the same wonderful thing everywhere, right? You want like the filet of fish sandwich. Obviously, doctors don't really like it when I use that analogy, but right? I love the filet of fish sandwich. I get them all the time. And you know what? In Toledo or Akron or Denver, it's always just as yummy. It's never any different. It's always the filet of fish sandwich, right? I've used 2 hospitals in the Bethesda suburbs for my kids, Bethesda suburbs of DC, and I've used 2 hospitals. They're radically different and they're owned by the same health system. All they have is the same logo on the door. The nurses are different, the doctors are different, the IT system's different, the culture is different, right? In healthcare, you're not buying the filet of fish sandwich, right? We're like an art gallery. Everything's radically different, right? But what employers like you want is you want to buy the same thing all the time, right? So we have to be able to provide that. Let me give you some cool ideas that are happening out there. This is Banner and Aetna working together. Banner is a powerhouse health system, as you know, in Arizona. They have some stuff in California and Alaska and so forth, but Arizona is their power market. And what they've been doing is they've offered this private label health plan to employers in Arizona. 2 things that got and they partner with Aetna to do it. Now, 2 things that got my attention about that. One, it's growing like a weed, which is interesting because you don't often see provider-run health plans growing very fast, right? And this is growing really fast. And second, they signed up a whole bunch of national companies, which should strike you as odd, right? Why would a national company care about Arizona? If I have operations in 30 states, including Ohio, why do I care about Arizona? What Banner said is, I deliver Arizona. You want to do Ohio? Talk to Aetna. They can set that up for you. But I deliver Arizona. Great brand, great services. I'll bend the cost curve with you. I'll provide very great services to your workforce and their families. I will deliver Arizona. You deal with Aetna to deliver the other places. That's not my problem. I mean, that's an interesting model because the truth is most health systems in Northeast Ohio want to be regionally relevant, right? That's what we all want. That's what the Cleveland Clinic wants. That's what University wants. That's what Akron General wants. That's what Summa wants, right? They all want to be regionally relevant. And this is empowering of that, which I like. The second thing we have to be able to do is we have to be able to make promises and deliver on them to the people in this room. So this is Select Health Share. This is one of the health plans run by Intermountain in Utah. And I know what you're thinking, but bear with me for a second. First of all, they offer that they'll keep your spending below 4% for the last 3 years. Okay, it's above general inflation, but hell, that's not bad. right? Below 4%. I mean, these are the things you're buying, right? This is a big deal. Check it out. It's worked well enough. They're actually now guaranteeing below 2% for the next 3 years. That's a solution. That's an answer. That's healthcare for the people in this room that looks like everything else you buy. It's general inflation. It looks like salaries and air and raw materials and supplies and everything else and paper clips. That's not healthcare redlining off the scales with chronic inflation. That's healthcare that looks normal. I know what you're thinking is Utah, great. A bunch of Mormons who don't smoke and drink, right? Have you been to Akron? I get it, I know. I'm from Ohio, I know. That was the first thing I noticed when I moved back to Toledo. I was like, gee, people are bigger. Anyway, I get it, right? But nonetheless, that's still an answer. What I love about this, by the way, is it's an answer. Forget that it's Utah. It's an answer, right? That's what we have to be able to do for the people in this room, right? We have to be able to say to you, I will keep it below 2%. Now, it's a quid pro quo, right? You give me, I give you. What do they have? So first of all, there's only one insurance product that you're going to offer, mine. You don't get to offer a whole bunch of stuff. It's like Henry Ford, right? You can have the car in any color you want, as long as it's black, right? You get my health plan. Second thing is, everybody, every worker you have, every family member takes a health risk assessment within 90 days. I want to know what's wrong with everyone. I don't want Google to know it. I don't want Amazon to know it. I want to know it. I want to know who's pre-diabetic. I want to know who has chronic disease. I want to know who has joint pain. I want to know who has bad knees, right? And then if you are overweight, you get weight management. If you're smoking, you get tobacco cessation. If you overuse the ED, you get ED hotspotting, right? And then if you have chronic disease, you're going to be on the phone with my nurses all the time. Good. It's a fix. It's a solution. You give me the keys to the kingdom, I give you 2%. I think this is lovely, right? I think this is a good model for the future. All right, if it doesn't happen at the network level, everything I've just shown you happens at the network level, right? If it doesn't happen at the network level, where is it going to happen? At the procedural or episodic level. So here we have Center of Excellence contracting, which is the big growth model of the last year. Everybody's trying to do Center of Excellence contracting these days, right? Because it feels better to you as employers. I'm not going to limit you to go to one health system. I'm going to pick and choose from all over Northeast Ohio as to who does what best. I'm going to provide that for you. This feels much better to us as employers, right? And we try to get low prices out of them. Grand Rounds is a company out in San Francisco that basically tries to facilitate that market. There are a whole bunch of these companies now, but they're the lubrication of this whole Center of Excellence world, right? By giving you second opinions and so forth. Here's an interesting example. This is Care First Blue Cross Blue Shield in DC. This is a Blues plan. But they have created this huge medical home network in their primary care physicians. And what they have is, they don't employ these doctors, they've just incented over time the creation of medical home models all over greater DC. So there are all these primary care physicians in a medical home model, right? Well, then they sent out a memo a few years ago to all those primary care physicians and said, who are your favorite specialists? And the primary care, send us their names and numbers. And the primary care physician sent those back, and look at what Care First did with them. They color-coded them by how expensive they are. All the specialists in greater DC. And the next year, the primary care physicians cut $153 million out of spending because they started referring to the cheapest specialists in the marketplace. Because they were incented to, and also because primary care physicians, if you ask them, will tell you good doctors are not the most expensive doctors. Bad doctors are expensive. They send stuff to their own surgery shops. They're paranoid and they overutilize, right? These aren't my words, they're theirs. Which is, good medicine should not be more expensive. $153 million. What physicians do you think were the least likely to change their referral patterns? In what employment model? Hospitals and health systems. Because they became loyal to their hospital or health system. So here's Chet Burrell, CEO of Care First, who said, I no longer believe and the model of hospitals employing physicians. I felt like calling him and being like, cows out of the barn, my friend. You're sort of late to the game here. They employ tens of thousands of them. But nonetheless, I think it's interesting that he was willing to say publicly, you know what, I don't believe in this model anymore. Because I think physicians should run the show and they should make the decisions about where patients go. Because they can save $153 million if they're harsh about where this should happen. I'm giving you another example of a counter model that is out there, which is a physician-run model that exists in fee-for-service. This isn't risk. This is largely fee-for-service, right? All right, it took me 48 slides to get to the federal government, but I finally got there. It was just a miracle if you think about 5 years ago. I would have started with 50 slides about the federal government, right? So here's CMS in the 2019 proposed rule, right? What are they going to require that hospitals publish? Anyone? Charges. That's interesting, isn't it? I mean, don't these bureaucrats know that those aren't real numbers? Don't these bureaucrats know that that's like fantasy football? Like, it's not real football. It's like in your basement, you know? These are weird numbers that hospitals and doctors use to negotiate with insurance companies, right? Why would they make you publish those? Here's another interesting detail. Look at this. They want it to be machine readable. Oh, that's a coincidence. Gee, that's odd. Why? What do they want? What do they want to happen in Northeast Ohio next year if hospitals have to publish all their charges? What's going to happen? They're going to get color-coded. That's what they want. They want you to be color-coded. They're going to put you in the newspaper. Who's the most expensive hospital in Northeast Ohio? Who charges this? And hospitals are going to scream bloody murder. That's not fair. And then we look like idiots. You know what I mean? Then the reporter's going to stick a microphone in your face. Why is that not fair? Well, those aren't real prices. What are they? They're this other thing, right? Why'd you publish them? They made me. Right? I mean, then we look silly, right? That's what they want to do. This is the Hawthorne effect. This is sophomore year psychology class, remember? If I make something public, it embarrasses you, and then you fix it. That's what they're after. That's what they're doing. All right, let me finish up here. I have 5 minutes, and then I'll take your questions. So there's this weird thing going on. Let me talk about Medicare and Medicaid real quickly. There's this weird thing going on for hospitals and health systems, which is called the Benjamin Button effect. You don't have to worry about this because it's Medicare, but it's always weird to see Trump and Cher together, isn't it? They're not friends. All right, so what happened? We all know that America's getting old, right? Northeast Ohio is getting old. Yes? Well, the thing is, that's true, by the way. But if you isolate and just look at Medicare, it's never been younger. Because you have these massive cohorts of baby boomers turning 65, and they're jacking the average age of Medicare way, way down. So the weird thing is, we think of America as getting much older, but if America is only Medicare, it's never been more sprightly and youthful. Right? The problem is that in 2020, you could literally demographically measure this almost to the day. That starts to switch, right? It's not a radical effect, it's a slow graph, as you can see. But what happens is the vanguard of the baby boomers are not turning 65 anymore. They're these guys who are turning 75. So what that means is they start to pull the age of Medicare back up again over time. That's a big problem. Why? Because look at the difference. But don't get mad at me. These are the government's terms, not mine. They literally call the 65 to 74-year-olds the young old. They call the old 85 plus. And I sugarcoated it a little bit. You know what they call the group in the middle? Regular old. But look at the differences, right? What you see here is, first of all, hospitals do an immense amount of surgeries on the young old. The number one DRG is hip and knee. Number one. What about the old? They do almost no surgeries on them. You know what they do to the old? Hospitalize them in giant numbers. If you're 86 and you go to the emergency room, you're going into bed. Get in that bed, right? You're not going to go home. I have an infection. I want to go. No, you're not going home. Get in that bed, right? Because they're afraid. You're frail. You're going to fall down, So, yeah. So they hospitalize them in huge numbers. This is a big problem. And the other thing is Those surgeries that they do on the young old are the most likely to go outpatient. So this is a big, big financial challenge, both for the federal government and also for hospitals and health systems in Northeast Ohio. Because it's going to get older, and Medicare is going to get notably starting getting older rather than younger in the years to come. All right, last thing I want to talk about, you see the Medicaid expansion. Ohio's already done so, but work rules are going to be put in place. This is the big push from the Trump people, is to put work rules in place. Ohio's trying to put it in place. A whole bunch of states are trying to do it. 4 states already have work rules for Medicaid. So that's the big change. And then last thing I want to talk about is, then I'll shut up, the ACO model, the Accountable Care Organization, right? I'll finish on this. What you see here is everybody's still on track 1. This is a Medicare, value-based payment model. Everybody's still on track 1. They're trying to push them out into the other tracks because they take more risk. Notice here, who's doing well in the Medicare ACOs? Docs, the physicians are. Again, this is the same point I've been trying to make to you all morning, which is we are either going to be the solution for the people in this room and Medicare, or we're the problem. Because the bureaucrats in the government are looking at this saying, gee, the physicians seem to be able to pull this off. 75% of their ACOs save money, but only less than half of the hospital-run ones do. Right? So I want us to win this, but we don't have forever. We're either seen as a solution or we're seen as a problem. All right, that's probably good. I'll put your slides up. Questions, thoughts, anything at all? Yes, ma'am.
With Medicare controlling pricing, do you
Yes.
see managed care companies going to a Medicare Plus modeling for pricing?
I do. I mean, I think it's an obvious win for them. I mean, remember, one of the fastest growing things in the country, one of the reasons Walmart's interested in Humana, right, is that Medicare Advantage is growing like a weed, right? I mean, that 1 out of every 3 people who turn 65 choose an HMO now. But I think with their fixed pricing, it's a lead-in, for other employers. Yes, sir.
So all of this discussion was focused on, and everybody's efforts seem to be focused on cost and
Yeah.
pricing and how do we get to that.
Yeah.
Why isn't anybody talking about what happens before people get sick?
Yeah.
We are the sickest country in the world by far. We're doing it to ourselves. Why aren't we looking at that and saying, hey, people, you got to stop making yourself sick and then your costs are going to go down.
Right.
What are the economics, or what comments do you have around that?
Yeah, it is frustrating, right? Because so much of this is behavioral, and it's I guess, and you do see some companies, you've seen this, right? Companies that have incented people to quit smoking or incented them to have a better body mass index, or so we have actually seen a little bit of that. But you're right, it's generally not the way we deal with it. We deal with the aftermath. We don't do a lot of stuff going into it, and we're not willing to charge. One of the things about the Affordable Care Act, right, is to lessen the ability to charge people different prices depending on their status, right? So we actually went the other direction in terms of less ability to sort of penalize people for bad behavior. So it's generally not part of our culture to say, you ate 5 Big Macs and you're gonna have to spend more on your health care than that guy is, right? And when we tried to do that, you get backed off. And told you shouldn't do it. So it's frustrating because you're right. To really make the country different, it doesn't have a whole lot to do with hospitals and health systems. It has a lot more to do with behaviors. Other thoughts, questions, thoughts? Pushback, passion, and agreement.
As hospitals and health systems try to remain relevant, do you see them aligning themselves with Medicare for All advocates in the next few years to avoid the disruption that's coming?
Yeah. I've not seen anyone. The nurses' unions are the only ones who sort of generally come out in favor of a Medicare for All model, single payer model. That's the only organization I've seen that's come out and said, that's what we want. Hospitals generally are not supporters of it. Physicians are certainly not supporters of it. I mean, at the end of the day, where's the money? You know what I mean? I mean, this is not a political statement. I just, you know, we're stone broke. You know, we're deficit spending every minute of every day. I don't see how that's financed. You know what I mean? And I think that's where the hospital people would come out. It's like, where's the money for that thing? You know? So no, I don't see that. I don't think that they would align with that. I think they would much rather fix it themselves, which would be better, I think. But no, I don't. Only the nursing unions have supported single payer. Yes, sir.
I'm a commissioner here in Stark County, and we
Yeah.
have a group of about 1,600 employees. We spend about $16 million a year in healthcare.
Yeah.
You know, we're trying to raise the employee share. We're going from 13 to 14%. We have a Cadillac plan, at least in my opinion.
Yeah.
What would you
Sounds like
suggest we do to manage our employees to get them more engaged in their healthcare?
Yeah. You know, it's fascinating to me that how little of that we do, right? I mean, if you think about it, the best health plans, the best arrangements are the ones where you are building a brand with people's behaviors, right? So the asthmatic gets an email from you saying, you know what, the pollen count is X today, so take your inhaler with you if you go out, right? And you know what, you have a rash and you went to the emergency room, and that's stupid, you sat there for 3 hours. There's an urgency center in Canton that's like 5 minutes from you. You know what I mean? We never do that, right? And we should do that, whether it's an insurance company or health system or you. It was encouraging that kind of behavior with constant reminders. And that's not unfriendly to me, that's friendly to me. I'd like to be told that by my doctor, you know, who says nothing to me ever unless I go in there and pay him, you know, a fortune. Like, I'd like to be reminded of how I could do better in different parts of life. Why else do we buy Fitbits and the iWatch and all that other crap, right? So you should be able to have a much more ongoing brand relationship with those people in the way they utilize. Yeah.
So with employers becoming more active in
Yeah.
creative solutions, direct contracting with ACOs,
Yep.
CEOs,
Center of Excellence.
Centers of Excellence.
Right. I mean, you probably saw, I forgot to mention it, but Walmart now is requiring people, did you see this? So Walmart has been incenting for spine surgeries and some other stuff. They've been incenting people to go to the Cleveland Clinic. Now they're requiring it. Walmart just moved to, like, for certain things. And you know why they did that? Why they did that was 1 out of every 3 times that a local employer sends, a local Walmart sends somebody to Cleveland for spine surgery, the spine surgeons at the Cleveland Clinic say, you don't need it. 1 out of every 3 times. Walmart wouldn't give us the numbers on this, but they said when they send associates for cancer care to the Cleveland Clinic, they wouldn't give us the number on this. A notable percentage of the time, they don't actually have cancer. And they're like, I don't know what your quack physician told you back there, but go home, you're fine.
So, you know, so we see a direction going that way. So the question is in that environment, finding creative solutions,
Right.
are you seeing employers' fiduciary liability increasing, decreasing, staying the same? Do they need to, you know, what do they need to do in this new environment?
Right. I mean, I suppose the fiduciary responsibility increases because the spending is increasing, right? I mean, that line's back up, which is intimidating and disturbing. So I think what they're doing is they're not getting activist because they want to. You know, people in this room want to make ball bearings and bikes and, you know, the things that you make, right? This is not what you want to do. Healthcare is complicated and political and scary, but you're doing it because you have to, because the line's going back up again, right? And if I can't offload $2,000 more in the deductible, and I think you're right, a lot of the plans in this market are Cadillac plans. You know, the deductibles are much lower here in a lot of places I go, right? So if that's the case, you're gonna have to get back in there and deal with it, right? It's not because you necessarily want to, although, you know, the people in this room are the best at it. But I think, you know, but you want a happy workforce, right? What do you want? You want people to stay with you forever, you know, who are happy and well taken care of, right? And what's happening right now is that we're having to get more hands-on in that, not because we want to, but because we have to. My gift.
Thank you very much.
Thank you.
All right. Good morning, everyone. So it's been a good 2018, and we're looking forward at the coalition to working with everyone moving into 2019. As a reminder, we do have a pretty large presence on social media, and at the rate of change that the market's going through, it's difficult to get that information out to you in our traditional means through the magazine or through other communications methods. So if you're on any of these social media apparatuses, make sure that you follow us, because we do post a lot of content out on the web. Our vision continues to remain the same as we work with all of you. So again, affordable quality healthcare benefits, healthier employees, to Chris's point, and creating cultures where employees can thrive really in both their health and in their careers. For us, 2018 was a large growth year. We'll talk a little bit about the growth that we've had in our pharmacy program, but certainly have added a number of team members to help us continue to deliver the quality customer service and experience that you all expect. And so you can see some of our additions up here. It's hard to believe, I know I say it every year, but just a decade ago we were sitting at 8 or 9 employees, and now we're at 40 employees, including some in different states and different parts of the country. So it's been a very fun time to work again with all of you and all of our clients and member organizations around the country in terms of advancing that mission. In terms of what we're trying to achieve, so we talk about what's our direction at Employers Health, and we use our GPS, which is growth, performance, and satisfaction. And so from a growth perspective, we want to add $150 million in new pharmacy spend to our program every year, which represents about a 15% increase year over year. From a performance perspective, we want to work with all of you to hold your trend as close to flat or negative as possible. And over the past 3 years, we've actually had either flat or negative trends across our book of business. So we've had a good 3-year run. And then from a high member satisfaction perspective, we deploy that member satisfaction survey on an annual basis. We look for your feedback in terms of what value you're getting from our work together. And we want to keep that at a 4.6 over a 5.0 scale. In terms of where we're heading moving forward, we want to have member organizations in 40 different states, and I'll share with you where we are today. We want to have over 300 plus pharmacy purchasing members. We're up at about 230 or so today. Member organizations, again, that negative 3-year pharmacy trend is what we're shooting for. Having a sales account management office outside of the state of Ohio, so as we continue to grow our membership into different geographies, finding that place to put another office and to house a core group of our team is important to us. Team members that find both financial security and personal fulfillment through their work at Employers Health, and then a team that's known for its culture, its expertise, integrity, objectivity, and accountability, which are some shared core values that we all came up with. So where are we today, and what did we accomplish in 2018? So you can see today member organizations in 34 different states. And every time I go out and talk to employers, it's always, it really is a source of pride to be able to say, this was 9 employers in Canton, Ohio. And most people respond, is that where that Hall of Fame is? I say, yep, that's where it is. But 9 employers in Canton, Ohio, now to 300 organizations spread across 34 different states. So clearly, the value that we created by working together right here has broad application across the country. We added 27 new member organizations this year to our pharmacy program. It represents about 180,000 new lives, and about 200 million in pharmacy spend. So we grew our program over 20% this year, which is absolutely fantastic. And as pharmacy continues to gain and continue to have a lot of attention in the headlines, we see a number of employers turning to the model that we've created in terms of both addressing the unit price piece and also addressing the utilization piece. From a performance perspective, so we're hovering through 3 quarters. The book of business is hovering around a 3% trend. So we'll see where we end up. But from a clinical achievement perspective, this drives a lot of where trend is going as well. And so you can see that our pharmacy team, which doubled this year, as Matt likes to say, from 1 to 2, our pharmacy team, including we have a new residency program. It's not new to us anymore, but it was new this year. We'll continue that next year, so we'll add a 3rd member of our team. But they've been really busy in terms of coming up with some custom edits with both CVS and OptumRx in terms of how do we help manage drug spend? How do we help manage claims before they hit your plan, right? So thinking about things more proactively rather than reactively. So, for example, new to market blocks, I put AviQ up there. How many people know about AviQ? A couple people. So AviQ, remember the big epinephrine, the EpiPen saga that played out, and EpiPen $600, and Mylan raised the price, and rightfully so, we were having a fit about it. AviQ is epinephrine in an auto-injector that talks to you. How much do you think AviQ costs? Between $4,500 and $5,000. So if EpiPen's at $600, AviQ's at $4,500 to $5,000. The reason most hands didn't go up from our employers is because the drug got blocked before it even hit your plan. So it's those kinds of strategies that historically, we never put those strategies in place until the drug hit our plan. We saw it in the reporting 6 months later, and we said, oh, we need to do something about this. A lot of the work that we're doing is on the proactive side, so maybe not as noticeable to you as plan administrators. So that's the good work of our clinical and account management teams. From a satisfaction perspective, we hit a 4.71 this year out of the 5-point scale. So above the goal. I will say that this is the 6th year we've done it. We've hit the goal every year. So thank you to those who respond and provide feedback. And we're certainly happy and ecstatic, really, that our work together is producing the results that you expect. From a website perspective, this is just a reminder. We really enhanced the amount of content that's out on our website. The magazine comes out, EH Connect comes out 3 times a year. Our team writes all the content for that, and I think it's some really good content as we think about what's been going on in the news from a pharmacy perspective. If you've not read this latest edition of the EH Connect magazine, I would encourage you to do that. There's some great articles in there. But we also post these articles and more out on the website under Benefits Insights. So we just posted a Beyond the Spreadsheet Pbm Pricing tips, and I share with you what we're seeing in the marketplace in terms of games that the PBMs are playing really to win business out in the marketplace. So as PBMs approach you or as consultants approach you with the latest and greatest in pharmacy, you can start to be aware of some of the tricks that go on behind the scenes, maybe to make deals look a little bit better than they actually are. And then some save the dates. So Cincinnati, March 20th, we'll have our PBM conference. And then May 15th, right here, will be our annual Innovations and Benefits Conference next year. So put those on your calendar and hope to see you there. And then finally, the Excellence in Benefits Award. So we call ourselves a professional benefits organization. We really exist to help all of you as benefits professionals be successful. And we want to recognize that success. And so that's why we created this award, and we've given it out twice now. But it's really meant to recognize the good work of you or one of your colleagues or one of your customers, for those of you from supplier organizations. And so nominations will open, typically those are in January. Where's Emily Clevenger? Is that still the same this year? Okay, so in January, we'll open the nominations. Please nominate a coworker, colleague, client. I think this is a great opportunity. Again, there's so much good work going on out there. This is a great opportunity to recognize that. And you can see we have a website for it, excellenceinbenefits.com. You can go there, you can go to our website, and you can get to the site as well, and you can submit your submissions online. So with that, just on behalf of our entire team at Employers Health, another big thank you to all of you for the work that we've done here in 2018. Certainly was a successful year in our eyes, and we wish each of you a safe and happy holiday, and hope to see you out at the member holiday lunches here in December. And if we don't, have a good new year as well. So thank you very much.